joining us today. I'm going to go ahead and call today's statewide substance use response working group subcommittee number 2, which is the treatment and recovery subcommittee, to order. It is 1:03 on my clock on August 29th, 2023. And Kelly, would you mind calling roll, please?
Thank you. Kelly Marshall for the record. Assemblywoman Claire Thomas.
Here.
Chelsea Cheatham.
Present.
Dr. Leslie Dixon. Lisa Lee.
Present.
Steve Shell.
Here.
Jeffrey Iverson. Madam Chair, we have a quorum.
Great, thank you. And I don't know, Kelly, if you're supposed to be, if you are sharing your screen, if you have a presentation.
Oh,
I do
I'm
not
sorry.
see that on my screen.
Thank
But I'm
you.
going to go ahead and move to agenda item number 2, which is public comment. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to Nevada Revised Statutes 241.020. If you would like to make public comment, Kelly will lead you through how to do that on this format.
Thank you, Madam Chair. Kelly Marshall for the record. If you're dialing in from a telephone from the US, please dial 1-253-205-0468. And when prompted, enter the webinar ID of 894-893-75298. And then you can enter a meeting passcode if prompted. The meeting passcode is 765594. And you can press *9 so that the host can prompt you to unmute. And Madam Chair, we also have Dr. Leslie Dixon joining. So she has joined our meeting as well as a member of the SURG Subcommittee for Treatment and Recovery.
Thank you, Kelly. We'll go ahead and take public comment now.
So for folks joined, Kelly Marshall for the record, for folks joined via Zoom, you can raise your hand and use the reactions button to raise your hand. You can unmute and I can see you unmute. So Ms. Laffey, are you desiring to make public comment?
Oh, apologies, I should be muted.
Okay, thank you. So Madam Chair, I don't see anyone unmuted. I don't see any hands raised. I've not received any *9 prompts.
Great. Thank you, Kelly. And just a reminder, if anybody didn't get to unmute yourself, we'll have another public comment period at the end. Moving on to agenda item number 3, which is the review and approval for the minutes, gosh, all the way back from June 23rd, 2023. If anyone has any discussion, we'll go ahead and entertain a motion.
If no discussion, so moved to accept the minutes from June 27th, 2023.
Thank you, Assemblywoman Thomas.
I'll second it, Dr. Dixon.
And a second by Dr. Dixon. Thank you so much. All in favor of approving the minutes from June 27th, 2023, please indicate so by saying aye.
Aye.
Aye. Any opposed? Any abstentions? All right, the minutes are unanimously approved. Moving on to agenda item number 4. Here's our work, y'all, for the day. We are going to be looking at our recommendations, our 2023 treatment and recovery recommendations. And this is a can of worms we're open to discussing at this time. And so I bring to this body, sort of a strategy for framing these recommendations. And I'd love to hear from all of you, but the way I see us moving these forward in a way that seems directed and intentional is to have sort of a bucket for treatment recommendations, a bucket for recovery support services, which would be peer recovery support services, recovery residences, et cetera. So all of these community-based recovery supports, and then harm reduction, which has a lot of cross-cutting elements with our prevention subcommittee. And so I kind of brought these to Kelly just to focus our attention. So we're very strategic with what recommendations are coming out of this subcommittee. And they're not, slanted just towards treatment or just towards recovery supports. We sort of have a balanced approach. And so I'd love to hear from the members what you think of this strategy to move our recommendations forward today.
Hi,
Madam-
Julie. This is Steve Shell for the record. Welcome back. We're so glad to see you back, I have to tell you. But I wanted to share, I think because we do have so many recommendations, I like the idea of placing them into the buckets you just described. So I'm in full support of that and hope that our colleagues are as well.
Thank you so much, Steve. Dr. Dixon, did you have a comment?
I'll just echo what Steve just said. I like separating them out. I like this and yeah. Good. Okay.
Thank you, Dr. Dixon.
This is Assemblywoman Thomas for the record. I like the separation. I just wanted you to give me the titles again, bucket 1, bucket 2. I know I got harm reduction for bucket 3, but if you can just repeat those again, and I'm in support. Thank you.
Thank you, Assemblywoman Thomas. Yes, so the first bucket would be treatment. The second bucket would be recovery support services. And the third bucket is harm reduction. And if we're in support of that, let's move to the next slide. So this is sort of the recommendations approach for our 2022 recommendations. As you may recall, Eric Schoen, I think it was Eric, brought up in the full surge, kind of what if our 2022 recommendations didn't move forward? Can we present them again? Or did they just go away? Do we have to come up with new ones, or can we sort of re-propose our 2022 recommendations? And so I believe the strategy across subcommittees is we can also we can look at our 2023 recommendations and we can look at our 2022 recommendations. They can be resubmitted. But the thing is, if we do look at our 2022 recommendations and we'd like to reoffer them as our current recommendations, we are going to elect one of our subcommittee members here to move that forward. And the way that that's moved forward is through one of those surveys. And if you remember offering recommendations through that survey previously, we had the justification, the action steps, any research or scientific literature that supports that recommendation. And in addition, so this is a little bit new, we're going to also be moving it forward by looking at the impact. In other words, how many persons across Nevada will this impact, right? So looking at the breadth of the impact, is it a small population? Is it a larger population, et cetera? We're looking at capacity and feasibility of implementation. Do organizations across Nevada currently have the capacity to bring forward this recommendation and implement it? We're looking at the urgency. Is it urgent, or is this more of a long-term recommendation, or is this something that we need to take care of right away? For example, something related to overdose deaths, right? That would be, in my brain at least, a very urgent recommendation. And then looking at how that recommendation advances racial and health equity. Does it advance racial and health equity across the state? So that's sort of the strategy as we comb through looking at our 2022 recommendations today. And next slide, please. Similarly, we're going to be doing the exact same thing for our 2023 recommendations that we've been discussing in this subcommittee. Define those recommendations. Again, electing a subcommittee member to move that forward through that survey. Again, looking at the justification, the action steps, the research that supports that recommendation. And then again, looking at impact, capacity and feasibility, urgency, and how it impacts racial and health equity. Does anyone else, I'll pause here. Does anyone have any questions, concerns, discussion around this approach? Okay, and I'm not hearing anyone say 1, 2, 3, not it. So that's a good sign. I'm going to take that as a good sign. And we'll just go ahead and dive in here. We're going to look at our 2022 recommendations. And in this, the expectation is that we review them, we discuss them. I hope you all had a chance to sort of look at the handout that was sent out. So looking at action steps that DHHS has already taken, any kind of legislation that's related to a previous recommendation. And then having said that, how we can maybe combine or amend 2022 recommendations, or if we even want to move them forward. So we'll go ahead and dive in. So this first one, this SURG recommendation 11, is that correct? Sorry, it says 11. Expand access to MAT and recovery support for substance use disorders, limit barriers to individuals seeking treatment, regardless of the ability to pay, and encourage the use of hub and spoke systems, as well as recovery support, including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and pursuing innovative programs such as establishing bridge MAT programs in emergency departments. And before we get started, y'all know I'm going to have an opinion on this, so I might just state it now. So some of these, when you look at the recommendation status handout that was sent out, it talks about the availability, some of the legislation that was passed. So extending coverage for telehealth services through Senate Bill 119, Assembly Bill 156, ensured availability of medication-assisted treatment in jails, detention centers, and correctional facilities for people with a diagnosis of opioid use disorder, and continuation of treatment on release or transfer. And then the Bureau notes that it's working collaboratively with DHCFP, is it Department or Division of Healthcare Financing and Policy, to support this division. Thank you. Once the individual is getting ready to be released, we work with DWIS, Division of Welfare and Supportive Services, I think. Maybe it's department. Never good with acronyms. To get resources, establish connections. Started in March and continue to support from a recovery point. services such as hospitality skills supporting businesses that they'll work at. So some of the work is already being done with part of that recommendation. So I guess my question to you is, picking this apart, regardless of ability to pay, do we already have a mechanism there? Encouraging the use of hub and spoke systems. In other words, the IOTRCs or integrated treatment and recovery centers. Is that something we want to push forward, or are we okay with what we currently have? Recovery support, including use and promotion of telehealth, considering modifications of inmate under emergency policies. So it looks like we had some legislation that impacts that already. There's already been work that has been done. And pursuing innovative programs such as establishing bridge MAP programs in emergency departments. Is that the gap? Where is the gap, I guess, is my question to you all.
Hi, this is Chelsea Cheatham for the record. Just reading this. I'm looking at the part where it says regardless of the ability to pay. And I know that Kelly, you had just brought up on the screen just some of the legislation and changes that have happened. Did anything kind of touch that regardless of the ability to pay? And how would we, like, what would be kind of an action step to ensure payment for MAT treatment for everybody?
This is Dr. Dixon. Yeah, I have a lot of trouble with that statement, limit barriers to individuals seeking treatment regardless of the ability to pay. That's a great idea. Who is going to provide clinical care for nothing? And for all the people who don't have much ability to pay. And as you know, a lot of our patients and potential patients got put on Medicaid during the pandemic, but they're now culling the rolls. And I haven't had a patient tell me yet they've been dropped, but there's several who expect it to happen. And then they will probably have to quit coming for treatment. And meanwhile, I just spent the last hour with a pharmacist from Indivior, and I said, well, you know what we really need? We need to get the Medicaid reimbursement rate up. It's just way too low to make taking care of a lot of Medicaid patients realistic. So no, we have made no progress as far as I can see in helping people who have, and you expect people who've been using a lot of heroin or fentanyl, they're not working. They don't have good jobs, and they probably don't have families who want to pay for this. So these people are really generally very limited in their ability to pay. So
Thank you, Dr. Dixon. And that's a great point about Lisa Lee for the record. That's a great point about a lot of folks being dropped from Medicaid. I know lots of folks that's happened to in our programs. I'm wondering though, we do have levers, right? We have federally qualified health centers or FQHCs. We have, gosh, I'm never going to get this acronym right, but CCBHCs. Somebody help me out with that. Certified Community Behavioral Health Clinics.
Behavioral Health Clinic.
Oof, I got it. It's only taken several years, but so we have CCBHCs and FQHCs, lots of acronyms that do provide these services regardless of the ability to pay. And what I mean by that is also for people who are not able to get Medicaid, right? Maybe they're undocumented and they're not able to access that. So there's a sliding fee scale option that's available. And so I don't know though, because we still have these vast areas, regions where that care is inaccessible. Am I right?
well, I'm also not sure that one of the big CCBHCs in Las Vegas, Bridge Counseling, I don't know that they have somebody regularly on staff that will write prescriptions. And it's big. So, I mean, I think one of our doctors would go over there and want to meet one day a week for a few hours, but mostly it's not being done. A lot of these agencies don't want to do this. And so it's not, And money is undoubtedly part of the problem, but the other is that, people with these substance use disorders, they need a lot of support, and high counseling that a highly trained therapist is going to do. That's not what they need. They need something at a different level. And so I don't know. There's hardly any of us that can, that in spite of taking away the waiver, I don't think that's making any big significant difference. I just don't think there's very many people that are doing this. Now, unfortunately, I somehow ended up on the faculty again of the psych department at UNLV. And I have students, medical students spending, I almost always have a rotation of a medical student. So we're starting to do something about the workforce, because these students are enjoying it, seeing it's a kind of a good group of patients to work with. So I think we may have more people that are interested down the road, but that's a fourth-year medical student is at least 4 or 5 more years before they're in practice. So I'm just throwing out some stuff. I'm not saying what the solution is, because there's so many problems and the solutions are many. But anyway, but there's just not enough people that are willing to provide this kind of care at the moment, maybe in 4 years.
Yeah, thank you, Dr. Dixon. And I think that's a good point about the workforce, the behavioral health workforce. That's certainly an ongoing challenge. Again, for the purposes of our recommendations, I want to be really strategic to keep it treatment, recovery support services, and harm reduction, because what I don't want is for us to get kind of lost in the weeds where we're going to the behavioral health workforce and we're kind of veering out there. Certainly that's a big part of treatment, but in giving recommendations to DHHS and some of our legislators that are part of SURG or are SURG curious, I guess, how can we pare this down? Where do we want to re-recommend this? Do we want to not re-recommend it? Is there some amendments in the language that we could pursue to sort of hone our focus? We still don't have bridge MAP programs in emergency departments. That might be kind of a low-hanging fruit to tune into. I know you were really passionate about that, Dr. Dixon. I'm just wondering what our thoughts are in moving this particular recommendation forward, or trimming or amending the language.
Well, about the bridge mat, Renown supposedly is doing that, and we've got a couple of hospitals down here that are doing it. So it's moving along, but not very fast, of course. Nothing does. And so we took the Nevada Bridge program took a summer break, so we haven't met for a couple months. So I don't know if there's been some progress, but I think that was one of our plan, was to have Marissa Brown talk with us and give us an update. As far as this whole thing, yeah, I think we need to keep it. This should be our number one recommendation for probably the next 20 years. So I don't see any reason to do away with this recommendation.
Okay, so you would like to keep it and keep it with the existing language?
Pretty much, yeah.
Okay. And so would you be willing to be sort of the elected person to move this forward through that survey, Dr. Dixon?
Move it forward through what?
Through this survey. Yeah. So we're going to be using the survey that we talked about for the 22 and 2023 recommendations, and moving this forward, we'll kind of elect like a good steward, if you will, to move it forward through that survey. So that would be, again, the justification, action steps, research, pertinent research, or evidence that supports this recommendation, and then looking at impact, capacity, and feasibility, urgency, and how it impacts racial and health equity.
When you keep saying that survey, what is that survey?
I'm sorry about that. My apologies, Lisa Lee for the record. So the survey is a tool that SEI has sent in the past for us to even make these recommendations. We would put our recommendation and then the justification, action steps, and research. It's similar to that. However, for all of the subcommittees, what we're doing is electing a person to move it forward. That person is responsible for entering that back into that survey to move the recommendation forward, whether it's a 2022 or 2023 recommendation.
But I mean, we are resurveying what group of people?
No, it's just a tool that you would enter. You would be responsible for entering it into the tool that will be sent out.
Yeah, so there
It's
is,
just an online. Mhm.
yeah. And
You just fill it out.
We're gonna send it out to who?
So that those recommendations get synthesized and then brought to the larger surge.
Oh, okay.
Correct me if I'm wrong, Kelly. Kelly.
So Kelly
Take it away.
Marshall for the record. So Dr. Dixon, it's a link that I provided in emails to you that if you click on the link, it takes you to a survey where you can submit recommendations. For the 2022 recommendations, we've already included justification and those like the research links, et cetera, because they were part of the 2022 report that was submitted in January. So you wouldn't have to do anything with those if you didn't change the recommendation. You could add to it, of course, if there was other literature that had emerged around expanding access to MAT. But then the piece that I think Chair Lee was referencing is you would at least provide like a starting point for impact, right? And feasibility for doing these things. So those categories, the health equity piece, just noting disparities in access to treatment. So you would, in essence, foster this recommendation by resubmitting it. You could use the 2022 report and then just provide your justification for the other elements. So I think that's the question is, are you willing to resubmit this on that survey link? And I'll send the survey link out after this meeting.
Sure.
Thank you, Dr. Dixon. Well, let's go to the next one. Okay, so this again is another 2022 recommendation resubmission possibility. This is SURG recommendation number 12 from that report. Implement follow-ups and referrals and linkage of care for justice-involved individuals, including individuals leaving the justice system and pregnant and birthing persons with opioid use disorder. And again, I will point you towards the report that was sent out, the recommendation status. So for that recommendation, there was a lot of work done, right? Let's see. So there was some policy work, including target number 5, increasing treatment for neonatal abstinence syndrome, pre and postpartum services through Roseman. I think that's the Empowered program, recovery, integration, support, and empowerment, their RISE program. Target number 6, provide opioid prevention and treatment consistently across criminal justice and public safety system. Carson City Community Counseling Center, Regional Wellness Center, increasing wellness. It looks like these are grants that have been provided since that report. And then the STAR program up here in Washoe County with the Department of Alternative Sentencing. These are all really great programs that have received grant funding. And also I would say an update for the Empowered program is they just received this huge, I believe it's a 3-year, but I could be completely off with that. I think it's a 3-year SAMHSA grant to expand their programming up to the north. So that is super exciting for pregnant and birthing persons who are using drugs. Then additionally, Assembly Bill 156, again, that was mentioned in the previous item, ensure availability of medication assisted treatment in jails, detention centers, and correctional facilities. And again, yes, so that's kind of a rehash of that. And then Assembly Bill 389 requires Medicaid program to provide coverage for incarcerated persons. This is kind of the work that I think the Division of Healthcare Financing and Policy was talked about in the previous recommendation. So that ongoing work of making sure that people exiting incarceration have access to mental health, substance use, treatment, all of the things. It says including case management in consultation, MAT, and community health worker services, which is really cool. Sounds like our community health workers can follow folks. If any, I don't know if Assemblywoman Thomas has any updates on that bill, but that sounds really awesome, and I don't know any additional information about it. And then Senate Bill 439, which requires Medicaid to cover prescriptions used to provide MAT for opioid use disorder. So that's the work that's currently being done around that. Again, we're looking at, should it stay or should it go? Do we want to re-recommend this, or are we pleased with the progress we've had regarding justice involved individuals and pregnant and birthing persons with opioid use disorder? And I will turn it over to you all. Kelly.
So, Madam Chair, Kelly Marshall, for the record, I just wanted to note that we're managing towards the October SURG meeting. And at that meeting, the chair will present the recommendations, and what we're aiming for is between 5 and 10 recommendations. So that's just a number people should keep in their mind.
Thank you, Kelly. And we still have to go through the 2023 recommendations. So I want to be kind of mindful. We've got one on our little tally right now. So considering this recommendation, does it stay? Does it go? Or do we amend it?
Madam Chair, it looks like Assemblywoman Thomas unmuted.
Yes, Assemblywoman Claire Thomas, for the record. I'm never in favor of taking money off the table, so I'm in favor of keeping this as is.
Thank you, Assemblywoman. I do want to point out one duplicative factor, if you will, when I was looking through these recommendations. So looking at pregnant and birthing persons with an opioid use disorder, and then looking at recommendation 14, which we haven't got to yet, but I kind of just wanted to throw it out here now. That recommendation also has a piece in it that that includes implement a specialized child welfare service delivery model that improves outcome for children and families affected by parental substance use and child maltreatment. So I kind of feel like those could be combined, because I don't feel like the child welfare and parental substance use kind of belongs with those kids that are needing to access beds. I feel like we're talking about two different populations there. And then with this recommendation, again, the talking about implementing specialized child welfare service delivery for children and families affected by parental substance use and child maltreatment, I feel like that kind of goes along with pregnant and birthing persons with opioid use disorder and should be decoupled from recommendation number 14. So I just wanted to throw that out there as kind of a factor in how we might reword this or something like that.
Assemblywoman Claire Thomas, for the record. I just want to make sure I understand. because we have such a high impact for our as far as fentanyl that's coming to our children of basically of teenage ages into young adults. And I just want to make sure that that group has specific, um, that we address that group specifically because it is really hurting um, that um, demographic when we look at um, how it affects our teenagers. And I want to make sure that we're not mushing everybody into one category because when you do that, um, it kind of like um, takes away from specialized services. Just my opinion.
Yes, thank you, Assemblywoman Thomas. I completely agree with you. And I believe that recommendation 14, as it was worded, mushes two completely separate populations. One, we're talking about youth, we're talking about adolescents, right? That need to go to a higher level of care. We need to significantly increase capacity, including access to treatment facilities. Basically, we have no beds. People have to send their kids out of state, right? They're sending them to Utah and Texas. And so I think that's one population. Would you agree, Assemblywoman? Like that's adolescents, but then lumped into that recommendation is families affected by parental substance use, which to me is a completely separate population, right? Yes, both affect youth, but one is talking about youth themselves who need treatment and are unable to access it. The other one is talking about, youth that are in danger because of their parents' substance use. So that's kind of why I was arguing to decouple those recommendations because it kind of waters down, you know what I mean? Like waters down that recommendation.
In agreement. All right, thank you.
So Madam Chair, Kelly Marshall for the record. So I'm trying to follow what you said. I'm not sure if I've captured this correctly, but it sounded like you wanted to decouple what was treatment and recovery recommendation 3, which also was the SURG recommendation number 12. And what you're proposing is implement follow-ups and referrals and linkage of care for justice-involved individuals, including individuals leaving the justice system. And then taking the second part of that and blending it with the SURG recommendation 14, which is implement a specialized, or actually that was number 12, implement a specialized child welfare service delivery model with follow-up and referral. So this is mirroring the language up here. And linkage to care that improves outcomes for children and families affected by parental substance use and child maltreatment and pregnant or birthing persons with opioid use disorder. Did I capture that correctly?
Kelly, I couldn't have worded it more beautifully. You did an excellent job. That looks great.
Okay, thank you.
Yes. So now looking at these two, does anyone want to be a good steward of either one of these recommendations? And remember, this would be, we only have 5.
Well, you have 5 to 10. You have 5
5 to 10.
recommendations you're dealing with, right?
Okay.
So overall, you have up to 10 recommendations to bring forward. And you don't need to winnow
Okay.
them today. We will meet in September, so there could be winnowing in September, but
Okay.
sorry, Kelly Marshall for the record.
Thank you, Kelly. I would like to volunteer for that second piece, just given the national data for how many kids are removed. because of parental substance use, it's almost 40%. And here in Washoe County, it's significantly higher than Clark. It is a huge factor in fentanyl. I was just doing a training yesterday, and fentanyl is a huge concern for our child welfare system just because of the child safety factors that it brings when parents are using fentanyl. We even have, at our family engagement center for visitations, parents have to wear smocks if they're continuing to use fentanyl just because of the potential for ingestion for little babies. And so this one is near and dear to my heart, and I'd be happy to take that on if that is okay with the group.
So Madam Chair, I'm just not sure about the first bullet point, which was the beginning part of the SURG recommendation 12, and whether there's a sponsor who would like to resubmit that recommendation.
How do we feel about bringing that top bullet point forward? Sorry, Lisa Lee for the record.
Unless Dr. Dixon, I'm going to say something about that. I mean, I think it's an important recommendation. It's, unfortunately, the bill AB 156 didn't quite turn out to be what it was in. I was not involved in creating that bill, but what it was intended to be, they took out most of the prison stuff out of that bill and put other stuff in it. So, but it's an incredibly important thing to do, because these folks that end up particularly in prison, are generally withdrawn, or they're already been withdrawn in the jail. And there's not a lot of effort made to treat them. And even worse, they're sent out when they are released, they're sent out with really not too much plans. I think there's been some effort to get their Medicaid restarted. I'm not sure how effective that is, but other than that, there's really not very much done for these folks at all, unless a few of them might be hooked up with one of these helping prisoners. Most people don't get hooked up with anything. So it's incredibly important, because these folks are going to probably relapse to substance abuse and or their criminal activity and end up back in prison if we don't do more for them. So.
Thank you, Dr. Dixon. So may I ask a follow-up question? This is Lisa Lee for the record. So given that, and you're familiar with AB 156, and then combined with AB 389 and SB 439, given the recent policy work and funding targeting justice-involved, incarcerated, and re-entering citizens, if you will, what work still, where's the gap, I guess, is what I'm saying. Is there an opportunity to revise this specific recommendation to address an ongoing gap? Or is this recommendation's language still capture what we would try to do, like being really intentional with our language?
This might be something to explore in terms of what's going on and how to help. Is something, I don't know if any of you know Dr. Elliott Wade. He is an addiction specialist. He's on the faculty with me for the addiction medicine fellowship. And he is really the medical director for NAFCARE, which covers a lot of the, for the much of the western part of the United States, the far west or whatever. Anyway, he's probably the person to talk to. How to really, what to really try to attempt, because he will be aware of what the barriers really are and where we might intervene with the barriers. So I don't know if you're looking for somebody. I guess I will volunteer for this one, since I can talk to Dr. Wade. We can get him maybe to be someone to talk to us in one of our future meetings.
Thank you, Dr. Dixon. Yeah, if you would have those conversations with him to sort of fine tune the language on this. It sounds like it might need to be revised a little bit, and then any kind of justification to help support that. I don't know. I think we have a pretty tight timeline to get these recommendations finalized and then brought to, I mean, we'll be reworking them as far as I understand in September. So there's an opportunity to kind of bring back that knowledge that you get from him. But then we're on a tight timeline because we've got to bring this forward to SURG and then get that, our annual report finalized. Is that correct, Kelly? It's a whirlwind from here, I think.
Kelly Marshall for the record. So yes, Madam Chair, that is correct. So we are meeting today to kind of refine the 2023 recommendations and determine which of the 2022 you want to resubmit. Dr. Dixon, I would be happy to meet with you and Dr. Wade to help you shape a resubmission of that recommendation by inputting it based on your conversation, if that would be helpful.
Okay, sure. Thank you.
Thank you. So I think we should probably move forward. I'm looking at the clock. All right. This next recommendation, which was recommendation 13, is to, to facilitate opportunities for entry into treatment and or recovery, ensure that Black, Latinx, Hispanic, Indigenous, and people of color communities or BIPOC communities are receiving overdose prevention, recognition, and reversal training and overdose prevention supplies such as fentanyl test strips and naloxone to reduce fatal overdoses among BIPOC individuals in Nevada. And some of the policy work that has been done, it looks like the Nevada Indian Commission, it says tribal opioid coordinator. So I'm assuming that's a new position. That's really exciting. And then it looks like SB4 primarily expands funds for a healthy Nevada beyond previous target population, which were seniors and persons with a disability. And it says, but DHHS regulations could target BIPOC populations. Could is a little different than shall, in my opinion. And it says, it looks like they're kind of looking at this in their RFA and taking this piece into consideration when reviewing applications. So that's good. We did have a presentation from Donald Griffin from Black Wall Street. If you recall, he's kind of got, newspaper boxes all over town in these hot spots that are full of naloxone. Gosh, it seems like every single day they're onboarding a new school. So they're working on kind of coaching and mentorship and peer support with high school students that are at risk and really getting them involved in service work like outreach, getting them involved in naloxone trainings. So I feel like there's a tiny bit of work being done, but so much more to do. We'll go ahead and look at, you talked about, this is just kind of a synopsis of his presentation to jog everybody's memories. going back to that recommendation and the language, let's talk about it. Because I don't really see any big policy or funding that's targeted to address disparities.
And Madam Chair, Kelly Marshall for the record. So I would just note that in the 2022 report, these were the action steps that were noted. So I think the part that you were focusing on was direct DPBH to allocate funding to projects that are specifically conducting outreach to BIPOC communities to ameliorate the harms of substance use disorder. There was a direction to create grant programs and then to also fund organizations that are already trusted entities.
Thank you, Kelly. Gosh, I just thought of something else. Sorry, Lisa Lee, for the record. In Sean O'Donnell's presentation, he also talked about a recommendation to do sort of a train the trainer in a lot of marginalized communities, right? So that would be a way to create, number one, a peer workforce. So that goes back to recovery support services, but it also intersects with harm reduction. When you're talking about overdose prevention and that, like Donald talked about the vending machines as putting vending machines in communities of color. So I think both of our presenters a couple months back talked about this, like pieces that we could integrate into this language, into this recommendation. So I will stop talking, and I just wanted to regurgitate some pieces of those presentations from a couple months back for you all.
So Kelly Marshall for the record. Chair Lee, so are you suggesting that that this recommendation should be woven in with some of the 2023 recommendation that we heard, or those would be too distinct?
Thank you, Kelly, for your question. Lisa Lee for the record. I think that there are some parallel points that we could weave in some of that 2023 recommendations into this recommendation specifically. I think there's an opportunity to review this. I was just kind of throwing that out to the committee members, more so for recall if we wanted to amend the language of this and sort of bring it to current day, if you will.
This is Chelsea Cheatham for the record. I agree that I think if we can incorporate the language from this recommendation into some of the 2023 recommendations, it'd be good, and I think it'd make it a little more streamlined to kind of limit the number of recommendations we are bringing forth, because I still think that this recommendation is very important, especially with the idea of making sure that we're funding harm reduction opportunities for the BIPOC community.
Thank you, Chelsea.
So Madam Chair, Kelly Marshall, I just wanted to move forward to the 2023 recommendation because these are recommendations to workshop that address both the enhanced peer support that you referenced, but then also prevention and overdose prevention outreach, including BIPOC, LGBTQIA+, and other populations noted in AB 374. If you would like, I could pull in the 2022 recommendation and put it on the slide so that it's all together and potentially people would see what they're looking at. Would that be helpful?
Thank you, Kelly. Yes, I think that would be very helpful. And then maybe we can just workshop this now.
Okay, so this is Kelly Marshall for the record. So what you see here is the recommendation from 2022, that's up the first bullet. And then the bullet under that is all we had identified for 2023. And then from the July 18th workshop, we had a recommendation related to outreach. So you see a bullet point here. Actually, I'll take this out. And then the peer support comes in. So I'm not sure how you want to organize that, but I think the content is there for us to work with.
This is Chelsea Cheatham for the record. Kelly, I know on the other document that you had sent, there was reference to an RFA, and I wasn't sure which RFA that was referring to. I think it might help me figure out what might be missing from this.
So, Madam Chair, I wonder, we did have somebody from DPBH participating, but I don't see Abe on right now to answer that question. I'm sorry.
Okay, Chelsea Cheatham for the record. Yeah, I was just wondering if there's anything like in the RFA that's specifically requiring, you know, working with BIPOC communities, or if that's something that possibly we could put in our recommendations, that any grants that are available, if there could be like specific wording on working with BIPOC communities or serving BIPOC communities.
No, I believe Kelly Marshall for the record, I believe the Bureau issued an RFA in May. So I wonder if that's the RFA they're referring to. But I can go back here, Chelsea, if you have a place you would want to just provide language. Sorry, I didn't capture it the first time.
No problem.
Madam Chair.
I'm trying to think of language. I'm just thinking it might be beneficial to put language in any future RFAs about, you know, serving the BIPOC community, but I'm having trouble thinking of language.
Madam Chair.
Yes. Is that Laura?
Laura Hale for the record. So the funding that comes through SAPTA, you know, the state agency comes from the federal bureau, and they always require the states to serve populations that are at risk. I don't think that they would allow the state agency to change those requirements that are at the federal level. I don't have the specific language off the top of my head, but I can get that and provide that to the members so you can see what's already required at that federal level. But when the money flows from the federal level through the state, those requirements are already in place, and it's not necessarily something that they could change at the state level. You know, unless there's specific state funding that's targeted to those efforts, then they could say, okay, these are state dollars, and we can specify what targets, what populations to target with that. I hope that helps.
Thank you, Laura. Chelsea, I was going to say, you know how I think the RFA or the NOFO that came out from the Fund for Resilient Nevada, I want to say in April, I did not see anything specific to any particular population, and that's for the opioid litigation dollars, so not coming from, any federal agency with specific parameters or anything. I'm wondering, how they have like funding priority areas. If we could make a recommendation for the division to create like, to have an explicit funding priority area that addresses disparities. Could we ask for something like that or no?
Chelsea Cheatham for the record. Lisa, that's exactly what I'm thinking. Yes. Thank you for explaining that so well.
No, well, it's hard because I think in pictures and it's so hard to translate to words, but you know what I mean, where they have the priority funding areas. So it wouldn't necessarily be like, it's a criteria for like in their rubric for grading the grant applications necessarily for each funding priority area, but it would be its own specific funding priority area. Or no, or would it, or is your idea to sort of have it be part of their rating and ranking of the grant application process in total?
Chelsea Cheatham for the record. No, Lisa, I think having it as a priority funding area would probably be the best idea for this one.
Perfect. Thank you, Chelsea. And then looking at the language for the really, really long, and I'm sorry, that was my recommendation. And I swear I'm not a French theorist. It's a lot, it's very verbose, and I apologize. I was just like really intentionally trying to make sure that various things were covered. However, having said that, I think there's an opportunity to pare down that language to just talk about overdose prevent. Like, I don't think it has to be overdose prevention, recognition, and reversal training. It could just be like overdose prevention, drug checking supplies. See, naloxone to me sounds redundant because it's already in there in overdose prevention supplies. And then drug checking supplies because we're now seeing xylazine and xylazine test strips available. So I want to be mindful of kind of broadening that language there. And then how else? I don't know. You all have to help me out with the language here and how to kind of weave a better recommendation.
Madam Chair, are you suggesting striking through such as fentanyl test strips and naloxone? Is that depicted accurately?
Yes, thank you, Kelly. I would also strike overdose prevention, recognition, and reversal training, just kind of getting rid of some of the redundancies so that we can make room to weave in some of the more current recommendations. We can just reduce redundancies. So we'll go for brevity here. Are receiving overdose prevention, drug checking supplies. And then Chelsea, what do you think of adding? See, I feel like the vending machines can be put into like, I think we could do parentheses for overdose prevention, naloxone, vending machines.
Chelsea Cheatham for the record. I like that idea, and I think instead of billboards, could we just put media?
And how about like culturally culturally relevant I don't know. I feel like so much of that media just really doesn't. You just know that they're paid actors and you have nothing, no similarities, right? Culturally and linguistically. Oh, I like what you're doing, whoever's typing. Appropriate. Uh-huh. Love it. And then there's one other thing, the peer support piece about really making sure that peer support training is delivered by people from underserved populations. So it's not like Foundation for Recovery coming into communities. It's somebody from the community that's doing the train the trainer. I think that's what Sean was saying. Whoever's typing, you're a complete rock star.
I think the jury's out on that, but thank you. Okay, so I think we have, this is Kelly Marshall for the record. We have a revised treatment and recovery number 5, which was, I think previously, like, I don't remember what number it was. Laura will be able to tell us. And then I think we're taking this piece out. And this becomes established priority funding areas. I don't think we have anything else there yet. So these are the two you have going, and then this is what Chelsea started.
Chelsea, I'm wondering if there's an opportunity to strike the first part of the recommendation that says to facilitate opportunities for entry into treatment and or recovery. I wonder if we could just put establish priority funding areas to ensure, and or how you feel about that language.
I like it.
So Kelly Marshall for the record, it seems like I can pull out this bottom part that we've woven it through other parts. Is that accurate? Okay. So I think now you're blending 2022 and 2023 recommendations, which is totally appropriate. Do you want to identify sponsors for these two recommendations going forward?
Thank you, Kelly. Lisa Lee, for the record, may I ask a question to the group? Is there an opportunity to, gosh, I don't want to make it even longer, but I feel that they go together. So again, in the spirit of reducing the amount of overall recommendations to the SURG, because last year I think there was way too many, honestly, to be effective, right? Sometimes less is more. However, I'm trying to make more into this to make less. So go figure, that doesn't make sense. However, are we able to add the enhanced peer support piece into this recommendation? Or do they go together, or do they not go together? What are people's thoughts?
Madam Chair, Kelly Marshall for the record. I would just note that what we lost was LGBTQIA+ and other underserved with the language down below. So I don't know if you want to expand both these recommendations, if that's even appropriate, or if that goes under the second enhanced peer support and the funding priorities is specific to BIPOC.
Thank you, Kelly. I would prefer to include LGBTQIA+ and others underserved communities. However, I'm gonna go with whatever this group says.
So Kelly Marshall for the record, just a reminder that in AB 474, I think I just used the wrong AB. Was it 374? Laura, help me.
Sorry, I think you got it right, Kelly.
Okay, that there are a number of underserved populations or special priority populations that were noted. So I think that would be totally in alignment with that.
Does anyone have any thoughts about including those or not including those together?
Madam Chair, I don't know if this will help, but because those references to special populations in the legislation is an overarching statement, maybe the SURG could make that as an overarching recommendation, you know, so that you don't have to reiterate that every time in every recommendation. You could say, you know, consistent with the elements of the legislation, all of our recommendations are intended to include all of these special populations.
Thank you, Laura. I'm in agreement with that. And I think we need to specifically call it out also.
Right. So like in the annual report, you could, when you come to the recommendations section, you could have a statement right at the top that says, these are, you know, cross-cutting things for all recommendations that we target all special populations.
I like that. What's the group's thoughts on this? We might need a small break for jumping jacks. Get our blood pumping again.
Multitasking today.
Okay, Chelsea, are you still with us?
Yes, I'm still here. I like the addition of that wording. I do have a question though. How many other recommendations are we going to be going through? Because if we already think we're not gonna exceed the 10, or if we're like, under, we might be able to separate this into two separate recommendations. And make the enhanced peer support a separate one. But I just don't know how many we're still going to be considering after this.
Thank you, Chelsea. One moment, please hold. Let me let you know. So there's two more in the 2022 that I see. And then I think we were going to workshop 2023, but we didn't have that many. We have veterans alternative pain treatment. Yep, 10 high, and then Sean and Donald.
So Kelly Marshall, for the record, I think the ones we haven't touched yet are the veterans alternative pain treatment and the 10 high. 10, yeah, high. So that would be 3. So I think you're under your 10 is what I would say. And you still have an opportunity in September when people fill out the survey and you come together as a subcommittee to come to consensus about what the language is that you want to bring forward in October, that you could drop or expand based on what your number is. But I think you want to walk out of this meeting with a slate of recommendations that are going to be submitted, with somebody doing the heavy lifting to say, here's the thought process in terms of health equity, in terms of impact, etc.
Chelsea Cheatham, for the record, since we are going to be under in the amount of recommendations we're going to have, how does the group feel about potentially separating these into two separate recommendations? One for establishing the priority funding areas for entry into treatment and recovery, and then a second for enhancing peer support for underserved populations.
I agree, they're two separate recommendations.
I agree with that, Chelsea. We will still need, kind of elected people to move these forward. Volunteers, if you will.
Chelsea Cheatham, I will volunteer to move forward the establishing priority funding areas to ensure entry into treatment.
Thank you, Chelsea. Well, I will throw myself into the fire and volunteer to move the enhancing peer support recommendation forward. So is that number 4? Is that 4 of them so far? I believe it is.
Mm-hmm. So we have, sorry. Oh, I need to go back. So we have Dr. Dixon. With the MAT recommendation. And then we have Dr. Dixon with referral and linkage to care for justice. So that's number 2. Implementing the specialized child welfare with pregnant and birthing persons with opioid use is number 3. That's Lisa Lee. And then we have established priority funding areas with Chelsea Cheatham and enhanced peer support with Lisa Lee. So we're at 5 right now. And then if you wanted to go back This is where we're at. So we already took this part away. So this is now part of another recommendation under SURG recommendation 14. And what you have left is the significantly increased capacity access to treatment facilities and beds for intensive care coordination to facilitate transitions and divert youth.
Thank you, Kelly. Sorry, my count was off. Lisa Lee, for the record, I'm wondering, Assemblywoman Thomas, you mentioned specifically adolescents as a population. And my question is there an opportunity to rework this recommendation?
Actually, I kind of like the wording in there because it gives it specifically targets our youth. Now, if you want to put an age group in there, you could. But for right now, I like it.
Chair Lee, this is Steve Shell for the record. So yeah, I agree with Assemblywoman Thomas. I could see us saying divert youth under the age of 18. I know that's a statewide issue at the moment.
Is everyone in agreement with that and marking that specific to under the age of 18? Because you're right, Steve, it is a huge issue. Huge. And
I
it sounds
agree.
like both of you might have a passion for this. Would either of you like to move this forward in that survey?
This is Steve Shell. I'll be glad to.
Thank you, Steve.
Okay. So Madam Chair, the next recommendation is engaging individuals with lived experience in programming designs and considerations. From 2022.
Thank you, Kelly. Lisa Lee for the record. So again, in that recommendation status report, it looks like Assembly Bill 403 states changes requirements for recovery houses from licensure to certification and preserving certain immunity from liability for volunteers of a recovery house for persons recovering from alcohol or substance use disorders. I believe this was the bill in which halfway houses, the language was revised, and it was changed to recovery houses. I'm pretty sure that this is in relation to the state and SAPTA specifically looking at adopting NAR certification recommendations. So the National Alliance of Recovery Residences, to sort of have a streamlined certification process for sober living homes, aka recovery residences. And I'm not sure it hit the mark in what it means to include people with lived experience or living experience. I would actually say living experience into programming design considerations. As far as I am aware, somebody can maybe tell me if that is happening, but I am not aware that that's happening. Sorry, Lisa Lee for the record. It does also state that the working with SAMHSA's guidance to include this. Currently, SAMHSA encourages organizations to involve individuals with lived experience. So SAMHSA is big on this. I will tell you, I'm part of a NIH and NIDA lived experience committee guiding research. There's a bunch of harm reduction research being done all over the country, and they are definitely they have people with lived in living experience at the table. So this is all also coming from NIH and NIDA, as well as SAMHSA. So I'm just wondering if we need to keep this as a recommendation here to encourage our state to also do that, if we need to change the language, and if we want to move this forward. All right, no one else is talking. Sorry, Lisa Lee, for the record. Kelly, I'm wondering if you can pull up that recommendation that I agreed to move forward, the enhancing peer support piece. I wonder if there's an opportunity to just include this as a sentence, since it pertains to.
Madam Chair,
Yes,
this is Assemblywoman Claire Thomas. If you could go back to that last slide, and it was just my, you know, when you're saying, yeah, if you can just transpose the living and lived experience, I think that that would be better.
Perfect. I agree.
So I can do it this is Kelly Marshall for the record. I can do it one of two ways. I can pull this up, which may make the most sense right now.
Thank you, Kelly.
So
Yes, engage. Oh, wait. Um, I think those are two separate things. I mean, they're in relation to each other, but I think we need to keep it enhance peer support. Yeah, so I think that's one thought, right? This is how we're enhancing peer support for underserved populations. But I think maybe a sentence before that is engage individuals that living and lived experience in programming design considerations. And enhance. I know that's a really long sentence. Seeing this all together, committee members, what are your thoughts? Do they go together or not?
Chair Lee, this is Steve Shell. I agree that they do go together. I like moving it here.
Any other thoughts? I'll still throw myself on this one and be happy to move it forward if everybody's in agreement.
Assemblywoman Claire Thomas, for the record, I'm in agreement. It looks good.
Thank you, Assemblywoman Thomas and Steve. Look at us go.
Okay, so I think we're taking this one out. But we'll leave that reference so we know this part of it was already presented. And then this comes away. So it was SURG, REC 18. And there, okay. So for
Kelly,
2022, yep,
was that all of the 2022 recommendations? Did we get through them?
that's all of the 2022. We, yep, that one's gone. So we got through all of them. And if you would like, I can go back to the presentation for 2023 and you can see what you have. Would that be helpful, Madam Chair?
Yes, Kelly, thank you.
Okay, so this slide is just a calendar of when the presentations happened. And so we've already addressed treatment and recovery, the role and importance of peers. We have not addressed treatment and recovery for veterans or the pain management. This we have already covered. We already addressed those recommendations. We addressed Sean O'Donnell's recommendations. So what we have left are the presentation from Abigail Began on serving veterans. Don't look. The alternative pain treatment recommendation, and just to note this, the prevention subcommittee recommended that treatment and recovery consider the following recommendations, which aligned with the recommendations that Dr. Nairizi provided. And there was just another comment from a SURG member that said, including training on opioid stewardship, provider training on alternatives to opioids, patient education materials on tapering, and options for pain management. So you could pull that up into item D. And then we have the Tin High presentation. So if you wanted to start with seeing if there was a desire for a recommendation, you would have, you could start here. And I don't think it's assumed that there will be a recommendation just because there was a presentation. So I would just note that for the subcommittee.
Thank you, Kelly. Lisa Lee, for the record, since I wasn't here, I was out on medical leave during these presentations. I'm going to lean on you, Steve, Vice Chair, since you were chairing that meeting and were present for those presentations. And I believe some of these folks came at your recommendation. So would you mind if I turn this over to you to sort of go over some of the recommendations that came out of those presentations, or if there is if there is a recommendation that comes out of those presentations? Would you mind, Steve? I'm sorry to put you on the spot.
No, you're fine, Chair Lee. Steve Schill for the record. So help me just understand, we need to go through each of these and decide if we are interested in moving any of these recommendations forward, right? Is that right, Kelly?
Yes, Kelly Marshall for the record.
That's correct.
So, I mean, what we took out were recommendations on a slide that said recommendations. They may not be crafted as a recommendation that the subcommittee would agree as a recommendation, or the subcommittee may, as you have before, want to expand that. But those were the 3 bullet points we had from Ms. Began's presentation. And I would just note that I believe that presentation was the July meeting where we did not have a quorum. But you should have the notes. That was part of the materials that were sent out to everyone and posted.
This Dr. Dixon,
Go ahead, Dr. Dixon.
Abigail was from the Reno VA, right?
Yes.
Because this Las Vegas VA is so different. It's like, well, how can we, because I mean, we have a rehab unit, we have a psych unit that does detox, we've got intensive outpatient programs. We have the company I work for does their methadone, and then they do. I think they have several providers that can do MAT. So it's kind of like, so some of these don't seem really pertinent to the Las Vegas VA. But I mean, what is it? What is it that's special about veterans that differs from all the other groups we've covered today? I think is how we need to word this.
Yeah, and Chair Lee, Steve Shelf, for the record, that's kind of what I took away from Ms. Began's presentation. And just like Dr. Dixon's referencing now, a lot of what Ms. Began recommended, I feel like is already included in some of our other recommendations and applies to some of the other populations that we're targeting.
Yeah, so could we maybe just add veterans to some of our lists?
Steve.
Oh, sorry, Chair Lee.
Lisa Lee for the record. So I feel like veterans are part of the legislation that guides SURG. And I agree with you, Dr. Dixon. And like I said, I wasn't present for the presentation, so I'm just kind of going over the materials as written, not as presented. So there's a bit of a knowledge gap there. But like the first thing, promote the use of ASAM as part of the clinical assessment and recommendations. As far as I know, that's standard practice, right? And so I'm like, well, but that's expected, right? That you, if you're looking at, treatment matching and which level of care somebody should have, and you're ranking the severity and all of the ASAM dimensions, like you're already using that tool. So I was a little unclear on why this body would be recommending that to push forward. And then the continuity of care, I feel like we all are promoting that. The problem is having all of those options available, not just for veterans, because I feel like when I am serving a veteran, I feel like I've hit the jackpot, right? Because I know that this veteran, I can link them with an army of social workers. I can get them into transitional housing. I can serve veterans because there are services for veterans. It's everybody else that doesn't come with an army of social workers, transitional housing, right? All of these other things. And so I'm just wondering if there's an opportunity, like in my head, veterans have they have access to all of these things. So we can promote continuity of care, but at the end of the day, all that promotion, we still don't have this full continuum of care for everyone to access. So that's a piece of this. And then the meaningful connection, sense of belonging and purpose, I feel like that's really where recovery support services come in, and the power of the peer and the power of mutual aid groups to assist individuals along their life course, recognizing that recovery doesn't happen in 28 days. It doesn't happen in, whatever treatment program length. It's a long, lifelong process where, kind of the role of a peer and the role of, peers in the mutual aid pathway, recovery pathways, is to help folks kind of uncover these things, this sense of belonging and sense of purpose. So I'm not really sure how to standardize that across the system necessarily in a recommendation. So I guess what I'm saying is I don't really know how to combine these into any recommendation coming out of this committee, I guess.
Chair Lee, Steve Shelf, the record, I agree with you. I mean, I think that's kind of what I took away from Ms. Beegan's presentation. I don't think it was a very helpful, presentation with helpful information, but I didn't walk away from it with any specific recommendations that I think our body may want to move forward.
Kelly Marshall for the record. Madam Chair, would you like me to go to the next recommendation?
Kelly, Lisa Lee for the record. I'm gonna let Steve drive this one as the vice
Oh, I'm
chair.
sorry.
This is all
Mr.
vice
Mr.
chair.
Vice Chair, Kelly Marshall for the record. Mr. Vice Chair, would you like me to go to the next recommendation?
Yes, please, Kelly. Thank you. So this was our next presentation. I'm forgetting who gave the presentation, Kelly.
It was Dr. Nyrezi.
Oh, yes, Dr. Nyrezi. Yes, he's based here in Reno and has opened up a new urgent care focused on pain and alternative pain treatment. I don't know how my colleagues feel, but he did give us some interesting thoughts here to consider. So the first one is to eliminate the need for prior authorization, either through legislation or persuade the insurance companies to sanction opioid alternative treatments. I know there's a lot of discussion about this in the industry. I'm not sure what Dr. Dixon and the others, how they feel about it. The next one was provide early access to patients who would otherwise be prescribed opioids if treated in an ER setting. The third was expand this strategic initiative to other areas of the state who are faced with the same opioid addiction issues. And the fourth was to include training on opioid stewardship, provider training on alternatives to opioids, patient education materials on tapering, and options for pain management. So I know that's a lot there, but maybe there's some here that we could try to consolidate. But I'm curious to see what the rest of our group thinks.
Mr. Vice Chair, Kelly Marshall for the record. I apologize, Dr. Dixon. I just wanted to note that it sounded to me like a SURG committee member, probably on prevention, suggested D based on the presentation, because he also presented at the April harm reduction SURG presentations. So these three were from Dr. Nyrezi, and this was a recommendation from another SURG member for you to consider. All inclusive of these bullet points.
So it's Dr. Dixon. Number A, I mean, yes, absolutely. We need, that is a major problem. You know, I've got friends who are pain anesthesiologists, pain management, who could do all kinds of things if someone would pay for it. And that's non-opioid, you know, a lot of the procedures that they can do, you know, in whatever. Some of you know about those anyway. And that's a big problem. They won't pay for it. You know, narcotics are cheap, so they'll pay for narcotics. You know, referring someone for acupuncture or physical therapy, all those things cost money. They don't really want to pay for it, or they limit how much you can go, how many visits you can see a physical therapist, for instance. So we would love to see prior authorization eliminated, but I don't think it'll ever go anywhere. But I think I would stand behind it 100%.
Thank you, Dr. Dixon. Steve Shelf, for the record, I agree. I don't know if this will really go anywhere, but I do like, you know, including it as, you know, a recommendation or combining it with maybe number B, but I think that it should be considered in this.
Mr. Vice Chair, Lisa Lee has her hand up.
Oh, yes, Chair Lee.
Thank you, Steve. Lisa Lee for the record. I love these recommendations. They're very succinct. I do refer people just on, you know, just, I guess, to, I don't have any conflict of interest. I don't financially gain from United Pain Care or whatever, but I do send a lot of people in recovery there. right, for pain, chronic pain does need to be addressed. Like, people can't be going around in chronic pain. That's a horrible quality of life. And for people in recovery, if you have an alternative for pain management that's not going to start the cycle all over again, awesome. They do take Medicaid, but this prior authorization thing, I think maybe more providers across the state would be interested in alternative pain management. And to Dr. Dixon's point, and to your point, Steve, this prior authorization is, I mean, I think that we do need to put this as a recommendation. So I would support that. I would also support, I think, sort of, the learning point from the overprescribing, Purdue Pharma debacle, right? That we all learned is that providers were easy to uptake knowledge around prescribing and seeing pain as a fifth vital sign and all of these things, right? This provider education that transpired. But what the gap was a real push for providers to understand how to titrate people off these medications, not just cut them off, right? Okay, you're done. You're showing signs of dependence. I'm washing my hands of you, because that person is then going to still, like, their dependence doesn't go away because the provider cut them off, right? And so I think one of the learning moments that at least I've learned, right, is that we didn't do a good job as a nation of really training providers how to titrate people off of these medications and not stigmatize people with dependence, right? Like, really be there for their patients. And this tapering options, patient education materials, all of that, I really feel like is an important gap in provider knowledge that needs to be addressed still, right? We're still not out of the woods on that. So I would definitely, from my point of view, push forward bullet point here, A and D.
This is Dr. Dixon. I just want to point out something. These always seem like things that the insurance company is just not going to go for. But, we pushed a bill through for psychiatric medications to eliminate step therapy, which is like prior authorizations. You have to do this before you do that. And it was only psych medications, but we got it through and the governor signed it. So, there's kind of like a model that it's worth trying. And we got some of the senators behind us and got it through. The insurance companies pushed back, but nevertheless, other people saw the wisdom in it. So I think, I think we definitely put A and B. I'm not sure I even understand C. I think that should be obviously part of A and B, but so now the training that they put in, this is part of a medical training. I'm not sure why we want to put that in there, since it should be part of medical training, but and other people who can prescribe. And that was the whole idea of AB 474 several years back, to get people tuned into this, but doesn't hurt to say it again.
Steve Shell, for the record. Kelly, you said number D was already recommended by the full SURG committee, right?
It was Kelly Marshall, for the record. It was a note when the prevention subcommittee sent this recommendation to you prior to Dr. Nairezi making his presentation. They just suggested, a member suggested, like, I would include training on ... So the two things that are combined here with an and, which I'm not sure that's appropriate. I'm just putting that up there for the group to look at. didn't include this piece. This piece was from a SURG committee member just wanting to make a note as this was forwarded to you.
Well, I think the problem is it's not specific as to who we're talking about. I mean, should there be more training? Should be expanded to more people? I don't know, but anyway.
Steve Shell, for the record, I like how you've reworked number A, Kelly, if the rest of the group agrees. Going back to what Dr. Dixon said, I think the step therapy bill being moved forward was a huge win. And like Dr. Dixon said, maybe we can build on that momentum that Senator Don Darrell Loop and others, really help foster. So I would also agree or recommend to leave out number C and just focus on number A. But how does the rest of the group feel about that?
Steve, sorry.
Chair Lee, yes.
Lisa Lee, for the record, I feel really passionate that is still a big gap. That again, the training on, these are all the lessons that we learned from that last wave of the opioid crisis, right? And I think that there's still gaps. And so for a lot of providers, they hear pain and they freak out, right? Because they don't know what to do. And I think they're so afraid to prescribe an opioid, but they can, right? They just don't need to give somebody 200 perks for what they could prescribe like 3 to 5 to 7 days worth, right? And then transition. So I feel like there's still a gap in knowledge, at least from what I've experienced and what the people I serve continue to experience. And so I don't know if we can maybe make a recommendation to, we don't have any control over the medical board and what kind of CEUs or education they push out to providers. They do have a substance use piece, and Dr. Dixon can probably speak to that. I know providers have to get so many CEUs around substance use disorder, but maybe the recommendation can be the recommendation to the medical board to include training on opioid stewardship, alternatives to opioids, and taper, and how to safely titrate from opioids. That would be my kind of language. And then the patient education materials, I don't think that's really within their wheelhouse. I think that's more like up to organizations to have their CHWs or health educators do. But I feel like those things can be tackled, just so the medical board has some, I guess, a path forward to kind of reduce some of the harms that have been caused by all this. And I don't know how anybody else feels, but I'm telling you, like Dope Sick by Beth Macy and Painkiller, the newest miniseries, have really fueled some passion for me.
So yeah, let me speak to some of that. Yeah, there was a recognition that opiates were a problem, and the doctors were mostly responsible. It was getting to be almost 10 years ago now, right? But anyway, so yeah, they passed AB 474 4 sessions ago, 5 sessions, whatever, and
in 2017.
Yeah, and so we now have, we have to look at the PMP. We have to limit our prescribing, and we have to do, anyone who's got a DEA certificate or Board of Pharmacy license to prescribe controlled substances has to do 2 hours of CME every licensing cycle. And so there's the law exists, and is it enforced? I have no idea. And but you can look at the data, and you see this nice little kind of things are going down. The number of prescriptions are going down. So of course, as a result, all we really did was send all these people to the heroin dealers. And but the problem with this I have is include. I'm not sure that's the right way we want to, the right verb here. So I mean, are people getting trained? You know, as they're supposedly going to train, they have to do the CMEs. But there's other providers that can prescribe, and I have no idea how. But then the law did apply to nurses, and it did apply to PAs, and I guess podiatrists and dentists can also prescribe. So all of them are under the law. Whether how many are doing that, I don't know. And so what is it we're trying, what are we trying to accomplish with this? To tell people do what you're supposed to do?
Vice Chair.
Chair Lee, yes, please.
Lisa Lee for the record. Dr. Dixon, thank you for that. Yes, AB 474 in 2017. I think it went live January 1st, 2018. And from my point of view, working in treatment, we saw some unexpected, well, it wasn't unexpected for me, but I think for a lot of people it was unexpected, but we saw a lot of people, like you said, okay, the prescription drug, like prescriptions go down and the illicit market picks up where the pharmaceutical market drops off, right? And so we saw a lot of people switching over and having behaviors that they didn't have before because they had, you know, a supply that was safe and it was covered by insurance. But then we saw a lot of providers that were scared of pain now, right? It's the pendulum swung the other way. And then they're like, you have pain? Like, I'm not going to treat your pain. And so I think there has to still, I feel like there is a huge gap around training on opioid stewardship, training on how to safely titrate from opioids. That would be how I would change that language to. Not like I would get rid of patient education materials, and I would maybe say promote training.
Yeah, that's a good word, promote.
Promote training. I'd get rid of the patient education materials. I would, instead of saying tapering and options for pain management, I would say I would get rid of options for pain management, and I would say and get rid of patient education materials and put and safely titrating from opioids, because I think that was the gap, is like people just cut people off when AB 474 was passed, and there wasn't that education that said, hey, you need to safely titrate people off of these drugs, because if you just cut them off, they're still dependent and they're going to go to this illicit market. And then that illicit market, as we have seen, is inherently more dangerous and poisoned, right? And so there's got to be some sort of remediation of this training gap. In my opinion, it has literally killed my friends. It has literally killed my family members.
Yeah, I think what they've done, what she's done here looks good. I think.
I like it as well. Chair Lee, I'm sorry that I'm going to have to hand this back to you. I have to sign off at this moment. I have to lead another meeting now.
Oh gosh, thanks, Vice Chair.
Thank you all.
Have a good one. Thank you so much.
Bye-bye. Thank you.
Bye.
Kelly Marshall for the record. So Steve Shell, Vice Chair, is leaving, but we do still have a quorum.
Thank you, Kelly. So are we good with combining those, or?
So are you saying to combine C into A?
No, I would say keep it separate.
Yeah, keep it separate. But now I guess it becomes a B.
B.
So then we need a sponsor for both.
Kelly, may I ask a question for clarification? Is this one recommendation or is it now two? Because I see it as alternative pain management recommendation as one with sort of 2 bullet points, not 2 recommendations, or am I
So
just
Kelly
delirious
Marshall
at
for
this
the
point?
record, so alternative pain treatment by itself is not a recommendation, so I was treating A and B as 2 recommendations. Unless the subcommittee wanted to say, support alternative pain treatment by or through eliminating the need for and promoting training on. Do you want to combine it all into one with that language?
Thank you, Kelly. Lisa Lee, for the record, I am in agreement with that. I did want to note that Assemblywoman Claire Thomas, I think, dropped off as well, so I'm
Oh,
not sure. Still
Yes,
have a quorum.
we do still have a quorum. We have 3 members. I
Thank you,
believe.
Kelly.
Rosalie, am I correct?
Yeah, Chelsea.
Sorry about that, finding my mute button. Yeah, I'm correct that you were 5 members total, so 3 would be a quorum and you're fine. Am I correct about your total number?
No, it's 6.
It's 6.
Mr. Everson,
And
so,
you do need 4.
okay.
So there's no problem with continuing, though I would ask that you hold a final public comment. Call for a final public comment before adjourning.
Oh, and I saw from Assemblywoman Thomas that she had to leave. I also wanted to note that we received a note that Dr. Dixon was referencing SB 167 from the 2023 legislature. I think when you were talking about the legislation that was passed, Dr. Dixon.
Yes, that is correct.
Okay, so Chair Lee, Kelly Marshall for the record. I think you can massage these. I think you can certainly, and Rosalie, please correct me if I'm wrong, but I think they could identify who would sponsor because they're not taking action. They're just discussing who would submit a recommendation. Is that true or no?
They could still discuss things since they're not taking action or anything else. If you don't have a quorum, if this is at this point, since we may have just lost quorum, I would say go ahead and at least call the public comments or adjourning at least the official portion first. And then if you want to go ahead and have some more discussion, you can, especially if a few are just volunteering to sponsor. But beyond that, I think I would hold till you have everyone else, because they're kind of making decisions on what is effectively going to be in this document later, that when you do have a quorum, you either need to, I guess, rehash this. I'm worried of less than a quorum making recommendations to having worked together, because then you're that second subcommittee kind of thing. But if individually you guys want to work on some edits to bring back at the next meeting, that'd be fine too. Or if you kind of organically get together and do a little bit, that's okay. I'm just trying to avoid that appearance of a second subcommittee.
Right. Thank you. So Charlie, I think we have, we've workshopped the alternative pain recommendation that could be brought back. And the other recommendation is kind of an intact recommendation from prevention that could be presented at the September meeting, hopefully for inclusion if the subcommittee wanted to. There would just need to be homework for us to figure out a process to completely build out all of those components that are in the survey. So we can go to public comment if you would like.
Great. Thanks, Rosalie and Kelly. So we'll move on to our second public comment period. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to Nevada Revised Statutes 241.020. And Kelly will again provide the information if you're dialing from a phone or how to unmute yourself. Go ahead, Kelly.
Thanks. Kelly Marshall for the record. If you're dialing in from a phone in the US, please dial 1-253-205-0468. When prompted, enter the webinar ID 8948937529 and then enter the meeting passcode 765594. Or please press *9 so that the host can prompt you to unmute you if you would like to make public comment. So Chair Lee, I do not see any hands raised. I do not see anybody off mute, except for Dr. Dixon. I think she's just listening. And
right.
no one has pressed *9. And I'll learn.
Great. Thank you, Kelly. And should we move on to adjournment since we have lost quorum? And actually, before we adjourn, Rosalie, would it be okay to go over the timeline just so that the members present understand kind of what we'll be doing at our next meeting?
Yeah, that would be fine.
Okay, great. So I'm going to take an item out of order on the agenda, and I'm going to move to agenda item number 8, which is our agenda items for our September treatment and recovery subcommittee meeting. And we'll go ahead to the timeline. So, Kelly, did you want to discuss this or do you want me to go over it?
That's fine. I'm
Okay.
happy to, or you can.
Well, I feel like you know this like the back of your hand, so I'll turn it over to you, Kelly.
Okay, Kelly Marshall for the record. So in addition to the subcommittee meeting today, we have a September subcommittee already scheduled. And that meeting is critical to discuss and to take action on the subcommittee recommendations. So the folks who have agreed to sponsor a recommendation while we had quorum will then be asked to submit in the survey, which I will send out after this meeting, the recommendation they received or that they agreed to sponsor, and then to complete the survey as fully as they can. In September, the subcommittee will discuss that as a whole and finalize by taking action the recommendations they're moving forward. That will be presented to the SURG at the October SURG meeting, where the SURG as a full body will discuss and take possible action on the recommendations from each subcommittee, including prevention, treatment and recovery, and response. And we'll engage, and this is still a little fuzzy, so Laura, please feel free to jump in because I think we're not scoring, we are scoring.
So the intent was for the subcommittees to have the qualitative discussion, so the impact and capacity and urgency, and also serving the target populations, and then the larger SURG will do the ranking.
And it's the ranking of the top 5 recommendations from all of the recommendations being provided.
Well, the top 5 is what we talked about, each member being able to put forward their top 5 overall. The SURG can submit up to 20 recommendations for the annual report, which is what we had as a number last year.
So then the SURG as a body will make a determination on that, and then we will have the slate of recommendations coming out of the September meeting. There may be recommendations that get sent back to a subcommittee or that are asked to be combined. We're trying to avoid that right now. But that may be the case. And then this subcommittee then will be scheduled to meet again in October to ensure that any work requested by the SURG is completed in anticipation of the December SURG meeting, where members will they will finalize the recommendations to be included in the SURG annual report. They'll review an outline of the SURG annual report, and they will receive a presentation on the DHHS annual report. And then the January meeting will be that approval of any changes. And so the changes identified in December will be approved, and the final report will be approved in January for submission, I believe, to the governor and the director of DHHS and potentially the LCB. Do I have that right, Laura?
I know it's the governor's office and DHHS. I don't know about LCB.
I may have the LCB. I may have just thrown them in for fun. Thank you, Laura.
Thank you, Kelly and Laura. Does anyone have any questions about our timeline?
I have one question, simple question, I think. I have the SURG meeting is, the full SURG meeting is Wednesday, October 11th in the afternoon. Is that correct?
Kelly Marshall, for the record, it is. Unfortunately, what we have heard is that Chair Ford is not available in the afternoon, so he has requested we move that meeting to the morning. But I don't know that that has been finalized.
Any additional comments on this? All right. Can we move to adjournment at this time, since we're way over time and we don't have any business that we can conduct? All right. Anybody move to adjourn? I don't think we need to, but let's do it.
Dr. Dixon, I'll move to adjourn.
This
a
is
motion
Chelsea, I
from-
will second.
In a second. All right. I'm assuming we're all three in favor, but let's do a vote. All in favor of adjourning?
Aye.
Aye.
Aye. All right. Thanks, everyone, for being here today and getting through this. I know it's really tough to workshop, and you did it. So pat yourself on your back. We got through it. I really appreciate everybody's time today. Have a great afternoon.